All right, thank you very much for the opportunity. Thank you, AUA. Thank you, SMSNA. Oops, sorry. My name is Deepan Jenny. I work at the Mayo Clinic in Arizona. Oh, sorry, I have no disclosures. So I have 3 topics here that I'm going to talk about: priapism, fertility, and ejaculatory dysfunction. It's a lot to cover in 8 minutes, and so I kind of just I kind of picked a group for each. So I'm going to talk about ones that maybe are a little bit more, can be a little more challenging. So one is recurrent ischemic priapism, and I'm going to focus on the medical management of it. I'll talk about the treatment of a hypogonadal male and fertility, and then just talk about ejaculatory dysfunction. Sorry, this should I be clicking or oh, here. So just a refresher on recurrent ischemic priapism. So AUA guidelines define this as the recurrent subtype of acute ischemic priapism in which unwanted painful erections occur repeatedly with intervening periods of detumescence. What's important when we're treating men with these conditions is thinking about their goals of care and their goals of their treatment. There's a lot of shared decision making here in terms of what we're going to be able to do for them. Is this going to be focused on prevention in terms of future episodes, or just strategies in which when they get them, how they're going to manage them? And so I just kind of created this table, which I kind of use for myself when I see these patients, and I kind of loop it into 2 categories. I have my non-hormonal options and my hormonal options. Some of these are, treated for the actual condition at the time of the priapism, the Sudafed or the ICI, and so just be, again, mindful of the goals there. In the interest of time, I'm just going to speak about 4 of these, and these are the ones I most commonly use, and that's PDE5 inhibitors and baclofen in the non-hormonal group, and then thinking more about the 5-ARIs and ketoconazole in the hormonal group. And so this is just sort of, hopefully some good take-homes for people in terms of some of the key points of these medications. So PDE5 inhibitors, many of you know, and we've talked about it many times, can be used in the treatment of recurrent ischemic priapism, and the idea is that it tries to reset that regular pathway that we know is regulated by nitric oxide. This can be done with daily Cialis or daily Viagra. One sort of caveat to be aware of is that for these patients who get nocturnal erections, and we'll talk about SRPE in a second, the idea is that maybe we give it to them earlier in the day rather than them taking it at night. We all know kind of the adverse effects, and then we want to be mindful of the concomitant nitrate use in these patients. Baclofen is a common one used for the patients with with recurrent ischemic priapism. This works through the inhibition of GABA. This can be titrated anywhere from as low as 20 milligrams a day to up to 60 milligrams a day. Patients have variable amounts of symptoms here, and so I always try to start low and then get them to titrate upwards. The biggest contraindication is really hypersensitivity, and then there are some caution with other conditions that are listed in the labels. Speaking now more of hormonal options, so 5-ARI, so obviously finasteride or dutasteride. This box conversion of testosterone to dihydrotestosterone. This can be done up to 5 milligrams daily, and there are papers that will actually report eventually tapering guys off to up to 1 milligram weekly. So if this works for your patients, it's not an unreasonable option. The challenge that I find is that these are often young guys, and so hormonal options are less desirable. These guys don't want to have subsequent ED or decreased libido and symptoms that might occur from the 5-ARI, so I tend to do what I can with the non-hormonal options first. If that all fails, I usually go to ketoconazole. So this interferes with the CYP450. The dosing could be anywhere from about 200 a day to up to 3 times a day, depending on the severity of the dose. So if you're at the TID level, you may need to consider prednisone, just because they do get adrenal suppression, and so it kind of needs to be given concomitantly. But this can work for patients really well as well. The last thing I'll kind of add in is sleep-related painful erections. This is kind of potentially a different subgroup altogether. When you talk to these guys, they'll kind of describe their erections at night a little bit differently. But in general, I treat them just like these recurrent ischemic stuttering priapisms. And again, I adjust the PDE5 inhibitor to be taken earlier in the day. We did publish a paper recently about a potential novel agent that we could maybe use in this group. We published it in a sleep medicine journal, and we used sodium oxybate. This is a medication commonly used in narcolepsy. Again, kind of works through GABA modulation. But it was for a patient who really tried everything that we'd exhausted on that list. A biggest challenge is that it has to be taken at multiple time periods throughout the night, and so it does still disrupt sleep, but it ends up giving them longer stretches of time where they're not interrupted. Next, I'll kind of pivot over to the treatment of fertility in the hypogonadal male. So again, fertility refresher, as we talked about in the last talk, exogenous testosterone does suppress spermatogenesis. This is our HPA axis, which we all know. The GnRH works on the anterior pituitary. You got LH and FSH, which work on the testicle for testosterone and sperm production. We have found off-label uses as per the AUA guidelines in terms of ways to try to raise testosterone while preserving this axis and preserving spermatogenesis. And so this is sort of my cheat sheet that I use in terms of fertility medications. I decided just to group them into 3 categories that we commonly see. We have our selective estrogen receptor modulators, which are Clomid or tamoxifen, our gonadotropins, being HCG or FSH, and then aromatase inhibitors, being anastrozole or letrozole. In general, my approach is to start with either a SERM or a gonadotropin, and then I add aromatase inhibitors on afterwards, and I'll talk about sort of what I do. And then I tend to favor Clomid just because it's a cheaper option for patients and often just easier to take a pill than to take an injection. So this is sort of a little bit about selective estrogen receptor modulators. So these work on the estrogen receptor, and they can block them and help mitigate their effects. You have clomiphene citrate, which can be as low as 12.5 a day, up to 50 milligrams daily. Some people also like to do every other day dosing, and then tamoxifen from 10 to 20. I find in general most patients tolerate this pretty well. Some do complain about some headaches and some nausea, but I tend to not get too much of it. I do counsel every guy, even though we're trying to preserve spermatogenesis, that there is some data about a paradoxical effect that we see in these medications. Some of the reports quoted to be reasonable, 5, 10, 15%. In reality, I've seen it probably in 1 or 2 patients, and from what we can gather, it tends to be reversible, but I do sort of counsel all patients before I put them on Clomid about this potential paradoxical effect. In terms of gonadotropin, so we have either HCG or recombinant FSH. HCG can be given as low as 500 2 to 3 times per week, up to about 3,000. Some people even push that a little bit more. And recombinant FSH, about 100 to 450 units. Recombinant FSH is very expensive, so it ends up really being the last line treatment for many people just due to cost. Generally speaking, I don't find many of these patients have too many side effects, but these are some of the reported adverse effects that can occur. Finally, aromatase inhibitors. I tend to leave this as the last line. I really use it on patients who are on TRT or some sort of off-label use to raise their T, and they get excess conversion of testosterone to estradiol. Either as anastrozole or letrozole can be given either weekly or up to daily. And I usually use a threshold of about 60 that I treat everybody, and between 40 and 60 I consider treatment, and below 40 I leave it as normal. And the last thing, I'll give some high level about ejaculatory dysfunction. So I think any person who's seen anyone with any ejaculatory dysfunction, if they have ED, just treat the ED first. Sometimes this fixes the problem and you don't have to go up any pathway in terms of their ejaculatory dysfunction. One thing which I didn't know where it really fit is retrograde ejaculation. This is kind of in the fertility space, but also in the ejaculatory space. Multiple etiologies, medications, prostate surgeries, neurologic diseases, diabetes. Treatment for these patients, really think about trying to remove the offending agent if you can. So, if they're really concerned about it, do try taking them off their alpha blocker. The treatment options are really going to be either pseudoephedrine or imipramine, and I'll talk about Sudafed in the next slide. So for these guys, I tend to give them up to 120 milligrams BID, and I do find a portion of guys do convert some amount from antegrade to retrograde. Again, depends on their etiology, but like a common example might be a diabetic where we do see some return antegrade. And so I kind of just give it around the time that they're trying to conceive or if they need that antegrade ejaculation for whatever reason. Premature ejaculation, so first line therapy for these patients, generally is sex therapy. I try to recommend. Sometimes it's just something kind of going on psychologically or something that they haven't sort of discovered yet. Topical agents can be used. I do try these guys on PDE5 inhibitors, again treating erectile dysfunction before their ejaculatory dysfunction. And then most commonly, medication will be SSRIs. This is taken from the AUA guidelines, and this is kind of just showing the various options that exist. We have our on-demand dosing and our daily dosing. Again, try to discuss with the patient what their goals are, how often they're sexually active, and what they would like to do. And then second-line options include things like tramadol or alpha antagonists. I find I rarely have to get to this point, and usually the first-line therapies tend to be sufficient for the patients. Just a little bit about SSRIs, just because if we're going to prescribe it, just to know a little bit about it. They block the reuptake of serotonin at the nerve synapse. Again, these can be daily or on demand, and important just to know the side effects, because these patients may ask you about some of them, but I always just be aware of potential withdrawal, especially on patients we put on daily SSRIs, if they're going to sort of acutely stop, and so kind of have to be mindful and be cognizant of of that taper. Last is delayed ejaculation. I think a lot of times this is caused by potentially an offending agent. Again, this is taken from the guideline. And so if they're on one of these, you can try to switch them. Obviously, as their urologist, you're not going to switch their methyl dopa, but you can ask and encourage them to talk to their family provider or their PCP to see if anything can be modified. Number 1, number 2, and number 3 treatment for delayed ejaculation, I think, is sex therapy, sex therapy, sex therapy. I think a lot of times if you encourage patients to embrace this and encourage them to spend time with a sex therapist, a lot of them may have really good results, but they need to be patient, they need to be open-minded and willing. If this doesn't work, I mean, I do explore hormonal abnormalities, so you can consider testosterone replacement therapy if they're hypogonadal. And then, medication trials really is the last resort. I don't find any of these work really more superior than the other. My drug of choice is carbergoline, but it's really, really last-ditch effort. These are my references, and thank you.